Well, hello and welcome to the JASN podcast, the monthly podcast where we highlight an exciting paper from a current issue of JASN. The papers may be clinical, they may be basic, they may be translational, but they're chosen to reflect the diversity of JASN content. I'm Dr. David Ellison, professor of medicine and chemical physiology and biochemistry at Oregon Health and Science University and a deputy editor of the journal. Today, I'm joined by Nina Himmerkus and Henrik Dimke to discuss their interesting paper entitled The Calcium Sensing Receptor in the Thick Ascending Limb and the Renal Response to Hypercalcemia, which appears in the current issue of JASN. So if you could both please introduce yourselves and tell us just a little bit about your background.
Well, first, I would like to thank you very much for the invitation to tell about our work. My name is Henrik Dimke. I'm a professor at the University of Southern Denmark in translational kidney physiology. As a background, I'm a molecular biologist, but I worked in physiology for maybe the last 20 years. I'm particularly interested in epithelial transport with a focus on kidney. So main study areas are the regulation of the paracellular transport and the transcellular transport, primarily focused on the divalent cations, calcium and magnesium. We are looking mainly in kidney, but also in intestine, and then also trying to understand the general balance. We use mainly targeted transgenic models, mouse models where we can ablate genes in the kidney or in the whole system or in specific cells. And we couple it with physiological evaluation and immunohistochemistry and other techniques. And in addition to that, I, of course, also teach medical students in physiology and are involved in quite a bit of research politics at my institution.
Hello, thank you. It's a real honor to be here. My name is Nina Himmerkus, and I'm a renal physiologist in Kiel University, which is in the very north of Germany. And I originally studied medicine and then got sidetracked in basic science. And now, since almost 20 years, I'm basically very intrigued with the nephron, and the renal epithelia, which are extremely diverse. And I'm interested mainly in the paracellular transport, and we are investigating claudins there. And I'm doing it with a technique which is called isolated perfused tubules, and we measure them electrically. And I think it's a very nice technique because you really have the real stuff. You take the native tubule and investigate it shortly after the mouse has been killed. And this is a different thing to some cell cultures which you sometimes investigate. And yes, and I think I will continue doing this besides, of course, and also teaching and supervising other students.
So let's get to talk about the paper then. I think many nephrologists mostly think about the calcium sensing receptor having to do with the parathyroid hormone and using calcimimetic drugs and things. But as you note, the calcium sensing receptor is expressed along the basolateral membrane of thick ascending limb cells. And I remember learning many years ago, it was actually well after I was in medical school, but many years ago, that activating the calcium sensing receptor along the thick ascending limb inhibits apical salt transport, leading to an increase in urine salt and water excretion, which was suggested to be a mechanism to reduce the risk of kidney stones when serum calcium concentration rise, and was bolstered by the observation that some people with mutations in the calcium sensing receptor waste sodium and potassium. Yet the observation that most such patients don't waste salt or water means that this was for a while categorized as a type of Bartter syndrome, but it's really been taken off the list of causes of Bartter syndrome. So that's sort of a little bit of a long introduction, but I wonder if you can summarize for us what was known about the effects of the calcium sensing receptor along the thick ascending limb before the work you described or we're discussing today.
Yeah, well, thank you very much. I think in general, there's been the suggestion that the calcium sensing receptor regulates sodium chloride transport in the thick ascending limb. And there was also a few patients that have been reported to have this Bartter-like phenotype due to very severe activating mutations in the calcium sensing receptor. But this Bartter-like salt wasting is not a hallmark, as you mentioned, in other patients with activating calcium sensing receptor mutations, as far as I know. And we also have investigated previously animal models, which has a mild calcium sensing receptor activating mutations, and they also don't display these overt signs of salt wasting or anything like that. The experimental literature on this, I have to say, is not fully consistent. There are some reports suggesting that the calcium sensing receptor affect the sodium chloride transport, and there's others that do not. It was interesting because we also had this thought, and already a long time back in 2012, we used the cinacalcet, which is this calcium mimetic that activates the calcium sensing receptor, or basically makes the calcium sensing receptor more sensitive to calcium. And we used that to study calcium sensing receptor activation in mice. And what we saw was the predicted that you activated the calcium sensing receptor in the parathyroid, and this reduced PTH levels, the parathyroid hormone levels, and you also got a low calcium in the blood, actually a pretty severe hypercalcemia. You saw an increase in the calcium in the urine, and we also saw this claudin 14 protein, which we will come back to later, to increase quite substantially, which is also in line with we get an activation of the receptor in the kidney. However, we never really saw any effects on sodium balance, which also left us kind of wondering about what this effect was. I should also say, and I'm sure Nina will come back to this later, that there's limited perfused tubal experiments that have really looked at the cortical thick ascending limbs. Some here says that it's usually the permeability that is affected. Others says that it's the transepithelial voltage or the sodium transport. And these studies, I should just say, more or less in the acute phase. So you apply calcium or you apply a calcilytic to the tubules and you measure. But the chronic effect it could be different, and that is in fact what we're really trying to understand in this manuscript. So to come back about what is known about the calcium sensing receptor along the thick ascending limb before our work, I mean, there has been one paper also published in JASN that looked at calcium sensing receptor specific deletion in the kidney. They used a 6-2 Cree model, which is different from ours, and that's one that is active in the podocyte and the nephron, but not in the collecting duct. And when they knocked it out in those segments, they didn't see any change in blood calcium, but these animals, they were unable to excrete a calcium load when they gave it. But they didn't really look in conditions with hypercalcemia, with high calcium in the blood. But there has been, I should also mention, an earlier study where they gave a hypercalcemic challenge to animals that lacked PTH. And when they did this, they saw that these animals were actually able to respond to this challenge. But when they did it in animals that lacked both PTH and the calcium sensing receptor in the whole body, they were unable to respond as well. So there's really something that suggests that the calcium sensing receptor could be important. The role in the thick ascending limb is not very understood, and especially in these conditions where you have perturbations of calcium balance. So it's not really clear how it protects against hypercalcemia and especially the downstream molecular mechanism. So this is really what we were looking at in this manuscript.
Well, one thing that might surprise people, although based on what you just said, it perhaps shouldn't be so surprising, is that mice lacking the calcium sensing receptor, your mice lacking the calcium sensing receptor, were pretty normal appearing at baseline. And even after several days of vitamin D-induced hypercalcemia, the serum calciums weren't changed very much. So one might think that by deleting an important calcium sensing protein from the kidney, you would really mess up systemic calcium balance, but you didn't find that. Can you explain why you think calcium metabolism wasn't disturbed more by the deletion?
I could say on that one of the earlier findings we had in animals that had an autosomal dominant hypocalcemia because of the gain of function mutations in the calcium sensing receptor really implies that activation of the renal receptor mostly occurred during hypercalcemia when a reduction in PTH is inadequate to really lower calcium levels. So basically what we think is that the parathyroid gland acts by releasing PTH, and that is the main regulator of calcium balance under normal conditions. And if calcium increases, then you reduce PTH and thereby lower calcium. But if calcium increases and this is insufficient to lower calcium, then we think then you get activation in the kidney. And it really functions like a molecular pop-off valve where you can then increase calcium into the urine when the blood calcium levels are too high. We can, of course, not exclude that there are tubular changes during baseline conditions. However, the major changes we really saw in this paper is in these hypercalcemic conditions supporting this observation. It also does appear that the calcium sensing receptor could be higher expressed in the parathyroid rather in comparison to the kidney. So that would indicate that maybe there is an altered concentration response to the circulating calcium in the two systems, but it's really not fully detailed, and the downstream signaling mechanisms for this may also differ. So
yeah, it's interesting. It fits with what I sort of teach medical students. That the calcium vitamin D system is is very redundant, and there are a lot of protections to keep the body in good homeostasis. So in some ways, it's not that surprising, but it did seem pretty clear that urine calcium excretion during vitamin D treatment was lower in mice lacking the calcium sensing receptor. I assume this was more along the lines of what you expected. And given this, why do you think you didn't see larger differences in calcium or even more in bone density?
I think I will try to answer this. So first, of course, it was what we expected, because now we really have the high calcium for the calcium sensing receptor at the thick ascending limb. And thereby we basically unmask this thick ascending limb contribution to what we wanted to see. And if you look then in the daily loss of calcium, which the wild type are able to do add on in comparison to the knockout, it's more or less 25 micromole. So if you calculate it, and if you calculate this then in milligram, it's 1 milligram calcium every day. And if you think about the plasma volume, it would be a disaster if it would stay also for wild type. So we really need the bone as sink for the calcium anyway. And then we are back to this PTH and vitamin D, and PTH is not there and vitamin D is there. So you can really get the calcium into the bone. But then the whole bone has 600 milligram bone mineral mass, which we also measured with the DEXA scan. But if you think that the hydroxyapatite is what you measure, 1/5 more or less is calcium, then you still have 240 milligram plus minus 40 milligram calcium in the bone, and then you add 1 milligram probably per day. But this will probably, until you are out of scatter, you need more days, I think. So the bone basically is a huge calcium store, and you add some more calcium, but really to see this, you probably have to wait longer. And indeed, we now included this 8-day little story in their study, and then you really see that the knockouts can't keep plasma calcium, and that they further increase during the experiment.
Yeah, I think that all makes a lot of sense and seems like it's probably true. So your microperfusion experiments showed that vitamin D caused a decrease in paracellular calcium permeability in control mice and an increase in paracellular resistance, but not in those lacking the calcium sensing receptor. So it looked like the mice required the calcium sensing receptor in order to change paracellular permeability to calcium. So my understanding is that you did not see a primary effect on transepithelial salt transport, sort of going against that idea that I was taught years ago. So would you discuss the electrophysiology results and how you interpret those?
To make this very clear, I probably start at a very basal level and just describe again what you need to transport calcium. So if you look at epithelial transport, you can go either transcellular or you can go paracellular. In both cases, you need a driving force. This can be either a concentration gradient, or it can be a voltage difference, a potential difference. So when you look at the transcellular transport, you have the NKCC2 in the luminal membrane, which is per se electroneutral, but the whole transport is combined with then a luminal potassium channel and a basolateral chloride channel. And these together so have the effect that you have a different basolateral membrane potential than you have a luminal membrane potential, or if you would like to write it easier, so the potassium goes back and you end up with a lumen positive potential. And this can be in the thick ascending limb rather high. So you have in mice 10 to even 30 millivolt. And this driving force generated by the sodium gradient into the cell, if you like, then can drive the calcium across the tight junction. Because the calcium per se, you have probably a very low concentration gradient, if at all, and probably even in the wrong direction. So you need this driving force. And from this, you already can understand that if you want to inhibit calcium reabsorption, you have either to lower the voltage, the driving force, or you have to close the door, if you like. You have to make the pathway, the paracellular pathway, more tight. And in our findings, so I think literature, you therefore find both. And in our case, the main focus or the main point was that you basically close the door for the calcium. But this ROM-K especially story is around already also a long time. So, and also historically, if you look, the calcium sensing receptor has been invented, if you like, in the 80s, and then it was very important also in the kidney in the 90s. And there is where just the tight junction physiology just started. So and before it was also for most scientists or clinicians or physiologists, it was thought that the paracellular pathway is basically a hole with not very much regulation. So the first idea was very logical, that you have to think, okay, I have to reduce the driving force, so the voltage. I think this is one explanation where people also first went for this transepithelial voltage, and then the cloudings came, and we learn more and more how well regulated this pathway basically is. I still think that you also can regulate probably also the sodium chloride transport, and you in some cases probably need to do it, but it's a little bit similar to the DCT connecting tubule collecting duct being able to reabsorb sodium and also reabsorb potassium if needed. So because also I'm always fighting with my students, because if I ask what is regulating potassium, then they say sodium, because the collecting duct is taking sodium back and excreting potassium. And then I'm always saying, but the body must be able to do both independently. And I think it's similar with this. In this case, you must be able to only reabsorb less calcium or more calcium independently of then changing the sodium chloride reabsorption in the thick ascending limb, at least under normal physiological conditions.
Yeah, I think the other thing that probably enabled you to think about these in a newer and different way is some of the observations from your own work with Marcus Blake, showing that the claudin expression is mosaic. And so I think, nobody would have thought in the 1980s that there are different pathways for sodium and calcium and magnesium. But knowing that, you can envision that you might have selective modification of the paracellular permeability for calcium.
Yeah, thank you. This would have been my last point now, but it's exactly true that you have different cells probably even so, and different sensors and different reactions. So, and then probably the collecting duct is again a role model, because there we are very used to different cell types.
Yeah. And so I want you to describe for a minute something that may be unclear to many listeners, which is you measure the, quote, equivalent short circuit current. And many people don't even know about Using chambers and what the short circuit current is. But I think I understand what you were measuring when you measure it and what it means. But I wonder if you could provide a pretty simple but clear explanation of what you're measuring when you measure the short circuit current, and then what you found when you compared the control mice and the mice with the calcium sensing receptor knocked out.
Thank you for the reminder. What we basically measure first, if we cannulate the tubule, is the voltage. So we measure the transepithelial voltage, and then we inject little currents and get voltage deflections. And from these two, we can calculate with a complicated formula, but we can calculate the resistance of the tubule. And then you have the voltage and the resistance. And then together with these, you can calculate a current. And we call this equivalent short circuit current because in contrast to other methods or Ising chamber methods where you clamp the voltage and then measure the current, we measure the free voltage and then calculate the current. And this current is basically correlate of the transcellular ion transport, if you like. And this is fairly consistently conserved if you change something with the calcium sensing receptor. There are little minor changes, and also we found some sex differences, but in general, this is kept the same, and especially the part which is the voltage, which would be the driving force, is really pinned to the same voltage under all conditions. And the resistance change we see is probably mainly due to the resistance in the paracellular pathway, because these two resistances are also in parallel, and it's very dominating because you have a really high transporting paracellular pathway, which would be in this case different to the collecting duct, where you really see more the cells working.
So the bottom line, as I understand it, by the fact that the equivalent short circuit current was not that different between the two groups, is that this is another piece of evidence that salt transport is not being primarily affected by the calcium sensing receptor. Is that a fair summary?
Yeah, this is probably not so clear also in the manuscript, but if you then give furosemide, you basically really have the furosemide dependent part of this transport, and this is very similar.
So Claudin 14 is known already to, or is believed to reduce calcium permeability, and at least in mice is not expressed very highly under control conditions. So it's only really apparent when calcium goes up. So please tell the listeners what you observed about the differences between the effects of generating hypercalcemia on Claudin 14 in the control mice versus the knockout mice, and how you interpret that.
Oh, thank you. I think in general, we hardly, as you mentioned, we hardly detect Claudin 14 in kidney on protein level. You can find one or two cells once in a while, but in general, it's extremely low at baseline conditions. And gene expression is also very low. And then if there's a type of chronic hypercalcemia, or if we use the calcimimetic CASR or other things like that, we can really see a very big upregulation in the thick ascending limb. And if you look at mRNA level, it's like a 10 to 100-fold increase in expression. Of course, it's very low and it goes to something, so that drives this big difference, but still it's pretty remarkable change. We also see small increments in Claudin 14 if you give, for instance, dietary calcium that also activates the receptor, but probably not as strongly as the hypercalcemia. And what is known about Claudin 14 is it's a pore blocking Claudin, meaning that when you take it and express it in cell models, it blocks the paracellular pore. So it's especially blocking cations and also, of course, the divalent calcium is being blocked by this Claudin. Its exact function in the kidney is not fully known. I mean, it's known that SNPs in the gene, they correlate with higher urinary calcium excretion and kidney stone formation. And it's also known that if you put the Claudin 14 mice, deficient mice on a high calcium diet, they have a lower fractional calcium excretion than the wild type littermates. So probably these mice are hyperabsorbing calcium under these conditions, and that's because they cannot block the paracellular pore. So the absence of the calcium sensing receptor in mice probably prevents the changes in permeability during hypercalcemia, and that's some of the things that we show in this paper to some degree. We think that the Claudin 14 is likely contributing to this process, but there could also definitely be other mechanisms involved, and that is some of the things that we're also trying to address in our future work. One important aspect of this is that we are trying to address really how long does it take for Claudin 14 to integrate into the junction and exerts this pore blocking effect that it has, because yeah, those type of things have not really been very well studied in intact epithelia, and especially not thick ascending limb that has a relatively complex junctional system with a lot of strands and so forth. So that's one of the things that we want to understand moving forward.
Yeah, that's interesting. And I might just use this as an opportunity to advertise another paper in JASN. So we have a series in JASN called Mechanisms of Disease. And we had a nice paper discussing Claudin's and kidney stone disease by Alan Yu and Josh Curry. For interested people, I would strongly recommend looking at that review paper because I think this is an area that's really just as Nina pointed out, really developed just over the past 15 years or so, and we're learning more and more. So, this has been very clear, and I think will help people understand. Maybe you could summarize for the listeners what you see as the most important conclusions or take-home points. And then I think, Henrik, you mentioned a few questions that this has raised, but if you have sort of big picture, where are you going to take the work from here?
Yeah, so I think overall, if I look at it, is that the key findings are that the calcium sensing receptor in the thick ascending limb is really essential for increasing the urinary calcium excretion in this condition of hypercalcemia. And I think it's nice to have this pinpointed somehow that we can really say, okay, this we knew already the segment was important, but this seems to underline it. And we find that when you have this deletion of the calcium sensing receptor, so the mice that lack it in this area of the kidney, they don't develop hypercalcemia under hypercalcemic conditions. We also see that the calcium level in the blood is the same after 3 days of hypercalcemia between the two mice. But if we go longer, as Nina says, we also develop this difference, actually showing that this lack of excretion is mounting it in the blood, but it takes relatively long to see it. So yeah, one other thing that I thought was quite interesting is that, when we delete the calcium sensing receptor, we don't really see marked effect on the urinary excretion of magnesium, which is another divalent cation, but it's moving through the same pore. So it's really suggesting that the calcium sensing receptor is regulating to a greater degree calcium, and how that is going. That's also rather interesting. The microperfusion data that Nina and the Kiel team really provided a lot of was showing that if you have a hypercalcemia, you have an increased resistance of the tubule and reduced calcium permeability in wild type mice, which is absent in the mice that lack the calcium sensing receptor. And also, as mentioned before, the driving force did not really appear to be changed. So we're really probably looking at a primary effect on the permeability. So interestingly enough, also here that the effects seem to be really big on the tubular level for calcium. We also saw changes in the permeability for sodium and for magnesium, but they appeared to be lesser than what we have there. So that also opens up a new an interesting avenue, I think, for further study. So,
yeah, I should have mentioned that, but I thought the fact that there were smaller effects on magnesium permeability is super interesting. I do not understand, because we know that if you have mutations in Claudin 16, you waste both calcium and magnesium. So I always thought that they really go together through the same pathway and would be affected the same. But it seems like the Claudin 14 really affected the calcium preferentially, which is super interesting. So I guess the last question I'll ask is sort of redundant to what we said. You both say you teach medical students. Are we going to be teaching medical students that when calcium sensing receptor is activated in the kidney, that the major effects are on paracellular permeability and not on transcellular sodium transport? Or should we continue to mention the latter, but emphasize that there's also a major effect on permeability?
Difficult question. I think I would probably try to reduce it to the fact that hyperreabsorption has to be stopped at this place, and this is the main task. And then leave it a little bit more open. I think for me, the evidence for the paracellular pore to be inhibited, at least under most conditions, is, I think, very clear. But I will not exclude that, because in the kidney you have a lot of these compensation mechanisms, and usually you have a huge scale of nephron and segment compensation you can add on and activate. And probably if you are really then at the edge, because you have in addition nephropathy, and you have in addition hyperparathyroidism, and you have whatever, then it still might be that then you also break with the voltage. But I think the main point in my view is that you really probably shut the door and not the driving force.
I love the way you say it. I mean, I think that when you need to increase calcium excretion, you have to, it looks like there is a major effect on the permeability to calcium along the thick ascending limb. And that seems to be a major effect driven by the calcium sensing receptor. There may be other ones, but I guess that's, I think, what I would teach medical students next year. So that's really great. I really, as I said, I love the paper. I love the area. You know, we're interested in thick ascending limb too, as you know, Nina, and I really appreciate the work that you both did and your contribution to JASN. Thank you so much for joining us today.
Thank you very much.
Thank you.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.